Welcome, everyone. Excellencies, distinguished guests, dear friends. Welcome to this annual PMNCH dialogue, Lives in Balance. And the theme for this year is Doing Better with Less and Rethinking Our Approach to Women, Children, and Adolescents' Health. This event, which we have been doing now 7 years in running, is often seen as a kickoff to the World Health Assembly Week. There has been overwhelming interest in this panel, and really thank you all so much for not only your interest in coming here, but for your commitment to women, children, and adolescents' health. We do meet at a bleak moment for global health, and even bleaker, unfortunately, for women, children, and adolescents. Aid cuts, shrinking fiscal space, rapid rise of regressive policies are just a few things to take note as we look at the landscape evolving in front of us. We also know that the rapid conflicts, often fought on the backs of women and children, from Gaza to Sudan to DRC to Ukraine, are having real implications on the realization of health and well-being for these populations. In a moment, you will be hearing about the data, the statistics, the progress made, the challenges that remain, and the rapidly changing geopolitical and geoeconomic scenario. And what does that mean? One underlying reality that remains is that women, children, adolescents are dying. They're dying on our watch, and they're dying of preventable causes often. A few days back, when Helen and I were talking about this, she said, these are not only lives in balance, Rajat, anymore. These are the lives on line in the landscape that we are talking about. But we also know that things can change. But for them to change, we need to work together in a spirit of partnership. Because when we do work together, we can change the realities for women, children, adolescents everywhere. 20 years ago, champions in this room and those not in this room said one thing, that status quo no longer was an option. And hence came together the Partnership for Maternal, Newborn, and Child Health. And in this 20th year of our existence, a big salute to you all for making sure that that happened and that we are today continuing to fight for women, children, and adolescents everywhere. But colleagues, our job is not done. In many ways, we probably have failed because they are still dying. And there are still many more reasons for us to continue to work together, to fight together. But it is because of champions like you in the room that we continue, and we will hear from multiple perspectives during the course of this evening on how we can not just be overwhelmed with this reality, but find solutions to make a difference. And one such champion, to whom it's a pleasure for me to call my boss, is Right Honorable Helen Clark, the former Prime Minister of New Zealand and Chair of Partnership. And with this, I would like to call her to give her welcoming remarks. Helen, over to you.
Well, thank you, Rajat, Minister, other panelists, and everyone who's come to tonight's Lives on the Line event, as I have relabeled it. So thank you for coming to this meeting centered around women, children, and adolescent health at this very special moment in time in global health. We've seen global health financing falter, in some cases outright stop. We're seeing many countries facing severe fiscal constraints, even at the very time when more domestic investment in health is needed. Now, what is on the line here is the progress that has been made on women, children, and adolescent health. We have seen fewer maternal deaths. We have seen more children surviving past their 5th birthdays. We've seen louder, clearer voices for adolescent health. But we're also aware that even before this particular financing crisis, the pace of progress was too slow for the scale of the challenge. And 5 years out from the SDG target dates, we're not on a path of acceleration, but at risk of reversal. So it is a special moment. We're all familiar with the components of the poly-crisis which we're living through, the climate disruption, the pandemic's long tail, the many, many conflicts, the rising inequalities, the high debt levels which are constraining so many countries now, and the growing pushback on rights, all this coming at the time of shifting and declining funding for global health. So, what to do, I think, will be the focus very much of this evening's event. How do we prioritize? How do we make sure that at this moment, women, children, and adolescents' health doesn't slip through the cracks? How do we partner? How do we finance? How do we hold each other accountable? And how do we support the voices of those in government who are trying to make a real difference? And let me give a shout out to Minister Motsoaledi from South Africa, who is so passionate about universal health coverage and ensuring that women, children, and adolescent health is part of it. Minister, I know you will speak to these very important priorities today. So, we've got 5 years till 2030. They will go fast. We have to act fast to make a difference. And we look forward to the reflections, insights, and commitments that everyone will bring to the dialogue tonight to inspire us on how we move forward. I'm looking forward to hearing the ideas. Thank you.
Thank you so much, Helen, for getting us started. And for our colleagues in the audience, just so that you understand how we are going to go about this, we have 2 panels that will follow after the opening keynotes and scene-setting remarks. Joined by my co-conspirators, Yasmin Ali Haq from UNICEF and Kathleen Sherwin, who will be moderating these 2 segments of the discussion. But without much further ado, may I invite you, Honorable Minister of Health, South Africa, for the keynote remarks, please.
Thank you very much, Program Director, Her Excellency Ellen Clark, the Chairperson of the Partnership for Maternal, Child, and Adolescent Health. Excellencies, distinguished members of the board, cooperating partners and friends, ladies and gentlemen, it is an honor for me to be accorded the privilege to deliver a keynote address at this important side event on the eve of the 78th World Health Assembly. As we gather amidst growing geopolitical tensions, economic uncertainty, and the climate crisis, one truth stands very clear. We cannot afford to retreat from multilateralism, cooperation, solidarity, and strong partnerships. This is a moment to work together and ensure that we deliver to women, children, and adolescents to save them from adverse events that exacerbate their vulnerability. I want to reaffirm South Africa's unwavering commitment to the cause of women, children, and adolescent health, and affirm that health is not only a fundamental human right as it is, but a cornerstone of sustainable development. The health of these subpopulation groups forms the foundation of the future of our nations, and South Africa remains steadfast in its efforts to prioritize and address the health challenges that they face. As we navigate the changing global landscape, including the shift in funding dynamics and changes in multilateralism, we must ensure that the most vulnerable are not left to bear the brunt of multiple cascading global shocks. I wish to congratulate you, Honorable Clark, for having led the unanimous approval of the PMNCH strategy 2026-2030. This strategy will drive real focus areas of reaffirmation and refinement of partnerships, focus on the adolescent and children, strengthening sexual and reproductive health rights, as well as accelerating actions towards addressing unmet commitments. In South Africa, adolescents make up 18.5% of the total population, thus requiring serious attention and investment with targeted intervention. Investment in adolescent health and well-being today will bring multiple benefits, leading to better long-term health for this generation and generations to come. As it may perhaps be known, that when we introduced the HPV vaccine program, we were intentional in ensuring that we protect the future women from cervical cancer when they come of age. I was at pains to convince the then Minister of Finance, our late Steward Pravin Gordon, that introducing the HPV vaccine is not an expenditure. It's a big, big investment. And I did calculations for him of how much money we spend in treating women with cervical cancer, just to keep them alive for 5 years, and how much money is needed to make sure that every 9 to 10-year-old receive their HPV vaccine. And fortunately, he agreed with me. But time and again, it becomes difficult to convince people because they don't see the results of that yet. Some might actually believe it's a waste of money because you're studying the girl at 10 and you'll only see the results when they are above 30. And so such investments, people don't regard them as very important. Regarding HIV and AIDS infections, we currently need to put about 33,158 children of between 0 to 14 years on antiretroviral treatment, and about 202,715 boys and girls between the age of 15 and 24 years on treatment for us to reach the UNAIDS 95 for these subpopulations. Of the 202,715 boys and girls, the girls make up 64% of this cohort, which is a very big cause for concern. This means that we need targeted programs to protect the girls and adolescent young women if we must win the war against HIV and AIDS. The glaring fact is that most probably these girls are infected by older males. Let me not say most probably. It has actually been shown by figures, at least in South Africa, that this is the case. The inequities in the world continue to tip against the girl children because of their unabating teenage pregnancies rate, which throw the girl child into structural poverty. The teenage pregnant girl has the higher chance of dropping out of school as compared to the boy counterpart. She also has a higher chances of being forced into looking for a job early as an unqualified person to feed the baby as compared to the male counterpart, thus making the girl vulnerable and looking to depend on either handouts or be abused by older men. Chairperson, we believe in partnerships because we together can go faster. We believe that platforms such as this engagement provide ideal opportunities to ensure that voices of the voiceless, especially from the low and middle income countries, are central to global decision making, and that our unique challenges and solutions are heard, understood, and acted upon. The commitment that we make will be achieved not so much through money, but through loyalty to partnerships and being able to hold one another accountable. We must be able to demonstrate our ability to do more with less. Mobilizing everyone to come to the table will ensure that each one must reach one. Then we can stop the onslaught against women, children, and adolescents. People are protected by human actions, and money follows thereafter. These efforts, coupled with the in-country support through initiatives such as Collaborative Advocacy Action Plan, the CAAP, rely on partnerships. For this reason, I would like to take some time to remind us of how important these are, particularly at the time when democracy is being eroded, inclusion made a villain, and smaller community-based organizations defunded. Through the CAAP, we are called upon to harness partnership efforts at the country level by deepening accountability for commitment made regarding women, children, and adolescent health. We must move with speed to implement revised approaches to commitment to accountability. Let us hold one another accountable, even at this level. Our commitment to Collaborative Advocacy Action Plan must demonstrate our ability to move from words to real facts and figures. We must demonstrate our ability and capability to turn things around so that the rural poor, vulnerable women, neonates, and children can have a renewed hope. We must demonstrate seriousness if you want these who are outside to take us seriously. We are also looking forward for further engagements with civil society and other partners on commitment made, priorities, and how we can work together to address the ills. We will use this meeting to mobilize all stakeholders, state and non-state, to come to the party so that we use a whole society approach to address the challenges that are facing women, children, adolescents, and young women. There is also an increasing role we can and must play regionally, aligning the efforts and collaborating, for example, in expanding regional production of commodities, enhancing exchange of practices, and collaborations. This is why we are making a call for an item on women, children, and adolescents to be included as a standing agenda item at the Africa Union Summit. And I regard this as very, very, very important. We thank partners for convening the discussion on the eve of the 78th World Health Assembly, which is a timely reminder of the need to keep women's, children's, and adolescent health high on the political agenda. We all need to fight for this. We can and must do better with less. The partnership has not been spared of the financing challenges facing development programs globally. I am hopeful that the meeting of the elders in South Africa in July 2025, the world will see the value of what we are talking about. The world must come together to promote the work of protecting women, newborn children, and adolescents if we hope to see a better tomorrow. As the chairperson of the Global Leaders Network for Women's, Children's, and Adolescent Health a network of 10 heads of state. His Excellency, President Cyril Ramaphosa is committed to champion women's health, children's and adolescent health at the highest level. Her Excellency, Honorable Helen Clark, you said I am very much committed to universal health coverage. And I am, and every time when I address women, especially women's organizations in South Africa, I make it known to them that they are biggest beneficiaries. Because in countries like South Africa, we are spending a lot on health already. We have already reached 8.5% of our GDP on health expenditure, which is a very huge sum if you compare us with our peer countries, even countries at the highest level of development. But we don't see the gains because the beneficiaries of such a system, that depends on capacity to earn. The beneficiaries are us men. It will never be women, children, or adolescents. And that's where our problem is. Unless we change that situation, nothing will come right. I was asking questions last week because many prominent South Africans, even prominent researchers and academics, believe that after the pullout of PEPFAR funds, our program of HIV and AIDS have either collapsed or are on the verge of collapsing. But I was asking myself, how on earth did we allow one country on which we must all hang and depend? How on earth did we do that? I don't know whether the Global Fund is here. I'm not attacking anybody, but I was shocked last week because in South Africa, when they call me in parliament, in the radio and all that, and ask me about this collapse, this imminent collapse, because President Donald Trump has pulled the trigger. And I tell them, no, we buy our own ARVs, up to 90% of our own ARVs. We buy them with our own fiscus, and 10% is paid for by the Global Fund. I kept on saying that continuously until last week I was told that this Global Fund, 1/3 of it is from Trump. I said, oh my God. Then you come to WHO, same thing. Then you go to UNAIDS, same thing. Then you go to universities, same thing. I said, oh, how did we arrive here? What are we thinking? So perhaps this is just a wake-up call, a big wake-up call for us to open our eyes. And in this instance, because the next replenishment round on Global Fund is going to take place in South Africa in September. The first one after this earthquake that has taken place is our time to show whether we want to continue and move forward without this albatross around our neck. The most painful part is to learn that in my continent, 11 countries, 11, are dependent on their health budgets, not HIV, AIDS, TB, and malaria, but the normal health budget. They are dependent on this one man who just looks and says, boop, boop, boop. Just with a tweet, the whole life of people falls apart. We should not allow that situation to go on. And in that regard, I think if we fight hard the battle on universal health coverage, we'll be able to win this battle. Let us dedicate ourselves to the task of saving the lives of our women, our newborns and our children, girls and adolescents. I want to finish by saying, at the height of the HIV/AIDS pandemic in South Africa, maternal mortality was a whooping 249 per 100,000 women. It was as high as Mount Everest. By 2018, because of these programs, which did not depend on your capacity to earn, by 2018, it was down to 86 per 100,000 life births. It just went high because of COVID to 111. We are now back down to 95 because COVID is gone. What am I trying to demonstrate? Is because when we started the world's biggest HIV counseling testing campaign in South Africa, there was a big debate in the Department of Health, in which I was minister then for the first time. A big debate that who pays how much. That certain people ought to pay because they've got money, certain, people have got health insurance, it needs to pay for them. And I said, if you want to fight a big battle like this, and you start putting money as your reference point, forget. Said when we launch this program, it shouldn't matter whether you are a billionaire or a domestic worker or a gardener or security. Once you test HIV positive, we put you on ARVs. And we did exactly that. And that's why we can boast that we are on the verge of reaching the Sustainable Development Goals when it comes to issues of maternal mortality. And I don't think we should allow that to be reversed by what happened on the other side of the world. It should depend on what we can do together. And I still believe we can do it. Thank you very much.
Thank you. Thank you so much, Honorable Minister. Those were very, very important remarks. And thank you for underscoring that that investment in women, children, and adolescent health is not just a cost, but an investment into a future. Colleagues, one thing with an event with such an overwhelming interest is that we actually have a very long list of speakers, so it will feel like speed dating at some point in time. So I do request your indulgence and of all the speakers if they could make their remarks as succinct and try and build off each other, and so that we can actually get to those solutions that both Honorable Minister and Chair asked us to do. And with that, could I please come to the next two presentations, brief scene-setting remarks from first you, Bruce, and then from Julia as well. Bruce, over to you.
Well, if we really want brevity, I can just endorse the minister's comments and sit down again. But maybe just to take a moment, and Honorable Chair, Excellencies, colleagues and friends, 12 months ago, we gathered, I think it was in the exact same room, and it was also, now someone's going to say I'm wrong, but I think it was also a beautiful summer evening like this, with the sun pouring in a little bit. A couple of heads are shaking. I think it was sunny. And that was appropriate because we were emerging from the gloom of the pandemic and the horrific toll, like you said, Minister, that it took on women, children, newborn, and the mental health toll, especially on adolescents. Over 100,000 excess deaths among women during that period. It was absolutely horrific. And 1 year later, yes, we're in a tough position, but there have been some important things that happened in this past year. We've seen, of course, the launch with even more power now, every woman, every newborn, everywhere, the Children's Survival Action Platform. We've got so many other strong, powerful tools with us. But we also have some evidence. We heard you spoke to the data from South Africa, Minister, but just 2 months ago, under Pascal's leadership, we published the maternal mortality report for this period. And not only did we see that drop in excess mortality that occurred during the pandemic, but we also saw a further, not a fabulous drop, but everyone talks about stagnation, but there was a slight decline in maternal mortality. And there were important countries that made important progress demonstrating what is possible. The problem today, as we come today, is still beautiful, sunny, early summer day, but we're walking into another pandemic, quite frankly. And that is, and I use the word, I'm going to prove I'm using the word appropriately. It's this pandemic of collapsing ODA. Because a month ago, we have to stop doing surveys because sometimes we see good news or promising news, but sometimes we saw what we saw just a month ago. We went out very quickly and surveyed 108 countries, went out to our country offices and said, what is this new insidious virus, let's call it, of the ODA collapse? What's this doing in your country? 80% of the countries said, we have had at least one of our health services interrupted. 70% said important services are being interrupted and systems, pardon me, as well. And we looked at the maternal child adolescent services. When we looked at the products for PMNCH services, when we looked at contraception, the availability of contraception, for every one of those, more than a 50% hit. And I emphasize those numbers because that's almost exactly what we saw during the pandemic. Now, during the pandemic, there was an incredible sense of urgency, a recognition of the vulnerability, those who were being left behind, the increasing morbidity and mortality. Now we're talking about it almost as if it's theoretic, but it's very, very real. And we are exhausted from the last pandemic. We just got out in the sun again, and all of a sudden it's raining again. But this is the time for partnership. This is the time for action. And the other thing we saw, though, every time we do one of these surveys, we go out and we give the headline numbers, right? The big bad news. But there was also some very good, impressive, and impactful news. And that was what the governments were doing. Governments were not waiting for the rest of us to get organized. In every single country, and under leadership like yours, Minister, we saw countries pivoting very quickly. They were taking mitigation measures. They were integrating their services. They were reprogramming their financing. They were protecting, to the degree possible, their community health workers. Ministries, governments were working very, very hard, and they were doing better for less, with less, for less. And when we talk about our theme here today, the governments are headed this direction, but they cannot get there without the commitment of their followers, the conviction of the fanatics like we have among us again here tonight. We need you behind the governments. And this is where partnerships like this one become so important because they bring us together. They provide a forum to keep us aligned, keep us behaving ourselves, keeping us integrated and following the direction of governments. Ladies and gentlemen, we are walking into another hugely dangerous period for women, children, adolescents, newborns. It is a time when we need partnership more than ever, and we definitely need to do a lot better with a little bit less. Thank you.
Thank you. Thank you so much for that, Bruce, and for bringing the sense of urgency for our action. And with that, I come to the final speaker for this segment, Julia Bunting, Head of Program Division for United Nations Population Fund. Julia.
Thanks, Raja, and good evening, everyone. Delighted to be here to represent the Every Woman, Every Newborn, Everywhere, the UNFPA Partnership and Child Survival Action. And I've been asked just to do a few slides just to share some of the numbers so that we're all on the same page. UNFPA is a partnership co-chaired by UNFPA, UNICEF and WHO. We work together to harness evidence, track progress and foster learning so that every pregnant woman, new mother and newborn has the best chance not only to survive, but to thrive with good health and well-being, no matter where in the world they live. And we collaborate with Child Survival Action, which is a renewed call to all partners to end preventable child deaths. As this slide shows, declines in maternal, newborn, child mortality and stillbirths were significant during the MDG era, but have stalled globally since 2015. Taking progress just on maternal mortality, the rates of decline have been 40% overall since the start of the century, but differ by region, by country, and of course, within countries. Recent data published just last month show that the highest rates are now in sub-Saharan Africa, with the region accounting for 70% of all maternal deaths around the world. And just over 60% of all maternal deaths occur in fragile and conflict and humanitarian settings. If the current trends continue, the target for maternal mortality reduction will not be reached by 2030. We see that 65 countries are off track to meet the newborn mortality target, and 60 countries are off track to meet the under 5 mortality target by 2030. And most of these deaths are entirely preventable. Interventions to prevent and successfully treat the leading causes of death are well known and can be delivered through primary healthcare with linkages to emergency healthcare as needed. Next slide. We've seen substantial improvements in under 5 mortality, mostly driven by declines in deaths of children aged 1 month to 59 months, mainly the result of successful scale-up of vaccination programs over the last 2 decades or so. However, neonatal mortality, deaths in the first month of life, now account for almost half of all deaths to children under 5. And there is still an estimated 2 million stillbirths per year, with almost half of these occurring during labour and birth. And progress remains uneven and the burden unequal. Next slide. The use of essential services across the life course is critical for improving health outcomes and preventing deaths. Each column on this slide represents an intervention. Important progress, as you can see, has been made in immunization, in skilled attendance at birth, and in access to safe drinking water. But less progress has been seen in relation to things like breastfeeding and access to family planning. And each dot on each column represents a country. And again, you can see there is significant variation of coverage of interventions between countries. And of course, with the dramatic funding cuts that others have already alluded to, we expect to see significant reductions in the use of services. And Bruce already made reference to the WHO Pulse survey showing exactly that happening. Next slide. Significant strides have been made in achieving universal access to modern methods of contraception through substantial investments in sexual and reproductive health and rights programs. But we know that those are particularly under threat in the current climate. And again, we've seen significant variations, with sub-Saharan Africa and Oceania having the lowest levels of coverage. Next slide. And we also want to recognize that we need to move beyond death, beyond health, to thinking about well-being. Well-being is a positive state, not merely the absence of ill health, and is influenced by social, economic, and environmental conditions. And WHO has developed a framework which has 8 domains of well-being across the whole life course. These include, as you can see, good health, the realization of personal autonomy and resilience, and opportunities for learning, for education and employment. Again, the Honourable Minister from South Africa made reference to the importance of education. Next slide. The abrupt and unprecedented scale of recent announcements to reduce foreign aid are expected to stall and even reverse progress. And women and children's health and survival are at particular risk. Bruce already mentioned the WHO Pulse survey, which highlighted the immediate impacts that are being seen on the ground. And in light of the reductions in ODA, concerted efforts and coordinated efforts are needed to support government plans and priorities to maintain the gains that have been made and prevent backsliding. EWENE and Child Survival Action are examples of initiatives to support the prioritization of critical life-saving interventions and to align and support national leadership under one plan, one budget, and one monitoring framework. Final slide. So I want to end by reminding us all of the ambitious but highly achievable coverage targets under the EWENE partnership that the maternal and newborn health community have agreed to support countries to lead to achieve. And importantly, note that work is ongoing to enhance this framework with quality of care targets, not just quantity and coverage, but quality of care, recognizing that more women and children die from poor quality care rather than lack of access. So again, reinstating the importance of partnership for achieving and protecting the gains that have been achieved to date. Thank you.
Thank you. Thank you for that, Julia. And thank you so much for our opening panel members. If I could ask you now to take your seats back in the audience, Excellencies, so that we can transit to the next session, which will be moderated by my dear colleague from UNICEF, Yasmin Ali Haq. Yasmin, if you can come here. And if I could also request the second panel members for the ministerial segment to kindly join us up on the podium, please.
Thank you so much. Honorable Minister, may we call you to the podium, to the stage? Monsieur, the second panel, we would like to, s'il vous plaît, if we can all have the second panel join the stage. Dr. Bashir. And we will proceed to introductions in the second panel.
So welcome to our first panel, I'd like to just introduce our panelists here today. We have Honorable Minister Haitham Mohammad Ibrahim from Sudan. We have His Excellency Dr. Abdul Qadir Gelgulu, Member of Parliament and DG for Ethiopian Pharmaceutical Supply Services. We expect His Excellency Dr. Jean Kassia to join us. I understand he's running a bit late. We have DG Osman Sise, who is the DG Health, and Social Action from Senegal. Dr. Isaac Bashir, who is the head of Directorate of Family Health and the Ministry of Health in Kenya. We have Ms. Emily Chirwa, who is the Deputy Director of Planning and Policy in the Ministry of Health in Malawi. So welcome to all the panelists. You see that we're looking at rapid fire, but these issues are so intense, and I'm sure they touch your daily work, not just your work, but also occupies your mind at all time. Minister Ibrahim, maybe I can go to you first. That the reports we have seen that today, especially from our opening panelists, point to the major issue in many of our countries while dealing with improving the access to quality of care, and that is the removal of barrier to access and use by those who are most vulnerable. In Sudan, these remain a challenge despite progress that has been made over the past decades. Maybe you could tell us a bit about what measures you are putting in place to address inequities in access to healthcare and how these have shifted given the recent funding cuts. Over to you, Minister.
Okay, thank you very much. I would like first to thank you for inviting Sudan to speak on behalf of the people of Sudan in this high-level dialogue on this important issue. Just from the presentation of Julia just now, that we have seen the trend of maternal deaths and neonatal deaths and under 5 deaths all over the world. I think despite all the effort, global effort, since 1970s, since Maata Declaration through MDGs, SDGs, universal health coverage, safe motherhood, all these issues. But till now, despite the progress we have seen in the presentation, but till now, if we made some sort of disaggregation, for example, by region, for example, we have seen that sub-Saharan African and countries like Sudan, for example, till now they are suffering. Till now, the maternal health, for example, in Sudan, maternal death is almost approaching 300, similar to some of the countries in Africa. Neonatal is 52%, under 5 mortality is 52%, for example. And there is a question. We are working on this very important issue now for 4 decades or more than 5 decades almost. And we are trying several efforts, several strategies, several approaches. Until now, the trend is either moving slightly up or down, or just zigzagging, like in neonatal maternal, for example. Over the last 20 years, neonatal mortality in Sudan zigzagging up and downs. And the question here, are the strategies usually we build together at a higher level, at a higher global level, are these strategies and approaches suitable for all countries? Do we need some sort of customization or country-specific approach for countries like, for example, for sub-Saharan Africa? We have seen sub-Saharan Africa over years. HIV/AIDS is high, mortality under 5 is high, all burden of disease is high, but we are trying the same efforts that are tried in different other countries. They work in other countries, but do these approaches work in countries like sub-Saharan? This is a big question I would like to start with. If I would like to talk about Sudan, like other sub-Saharan countries, but the war in Sudan, this 15th of April for 2 years, make the life even worse in Sudan. And the file of maternal and child health services even worse. But despite that, in the country, coming back to the question, we are trying the best to ensure that the continuity of essential services. From the beginning, we put like 5 priorities for the country since the start of the war. And among these 5 priorities, we put ensuring continuity of mother and child health services, one of these five priorities for the country. And I think by our little resources and the support from our partners, from UN partners and from other partners, we made some success. At least we keep the momentum of ensuring continuity of the services, like essential services, like vaccination, for example. When the war started in the first 3 months, like a shock at the beginning, like a paralyzed at the beginning. Everyone is seeking how to move out of the country. But after 3 months, when the Minister of Health come on the ground, bringing everyone again and sit together with remaining UN agencies and partners, we built some sort of interventions and we'll be able to even to continue providing services, like after 0 dose arriving for a while, but again we start re-implementing vaccination through EPI throughout the country, including the areas that are hard to reach, like Darfur, for example, where the conflict is hard, through our partners from MSF, through UN agencies, and through other partners. But I would like to say that we built like a triangle of 3 approaches during this war. The first one is integrating sexual, reproductive, maternal, neonatal health services within the humanitarian package. Because we are in war, that means all resources coming to the country are humanitarian resources. We put improving maternal and child health as part of our priorities. That means to be supported and to be budgeted from the humanitarian response, and that I think it is one of the strategies that improving the health of the children and mothers in the country, and even more through doing that, even from the domestic and national resources, we ensure some of the funding for mother and child health services, and we have seen that in improving the pediatric hospital, for example, free services for renal dialysis, ensuring insulin, for example, for children with diabetes, and also addressing some of the maternal health issues like sexual violence that are repeatedly have during the war. We built like a system for that with the partners. It is difficult to do that unless to integrate that within the humanitarian. The second one, in brief, it is strengthening the partnership. And from this desk, I would like, on behalf of Sudanese people, to thank all our partners in UN, in UNFPA, in UNICEF, in WHO, and other UN agencies, and also some of international organizations for their presence in the country and for their contribution, and also for being like a vehicle transmitting services for hard-to-reach area that is difficult to be reached by Sudanese. The third and the last one is scaling up services with focus on equity, providing these services for all mothers, all children, regardless of their situation in the country, where in the areas controlled by SAF or controlled by RSF, in West, in South, in Darfur, in Kordofan. And I think through this, we made some success. Vaccination rate increase, controlling of vaccine preventable disease better than before, introducing of new vaccines, for example, like malaria vaccine.
Policies and delivery models to safeguard these gains? And what are the most promising strategies do you feel are going to help the country not just stop slipping behind, but also improving?
All right. Thank you so much. And thank you for recognizing Malawi on this important discussion. Yeah, so maybe just also highlight that Malawi is, if I'm to share our total per capita expenditure for health, I think we are amongst the lowest. But suffice to say that despite that we are spending low, the gains outweigh how much we are spending. Our service coverage stands at 45%, and that compares well with other countries within the region that are spending even more. Unfortunately, we have stagnated at $40 per capita. We have not moved. And one of the reasons is population growth. So we are growing so fast that the growth is dampening the growth in the per capita expenditure. And unfortunately, some of the people contributing to this are the adolescents. So personally, it pains me when I see adolescents breastfeeding instead of going to school, instead of going to play with their peers. Yeah. So in terms of the interventions that as a country we are implementing, suffice to say that we have seen the gains over time. Our maternal mortality ratio has gone down. It's now stands at 224 after the recent survey that we did, but also even neonatal has gone down to 19. But now with what has happened, our fear is that actually when it just happened, we thought HIV was going to be the the very first one to be hit. But when we did our analysis, we realized that actually it was maternal and neonatal health that has been hit. So out of the total amount that was going towards that, we have lost about $22 million. And out of the $8 million from there covers family planning clinics, but also outreach clinics. Something I wanted also to share in these conversations is the issue of the Paris Declaration on Aid Effectiveness. And unfortunately, most of our partners are aware of that we need to let countries lead. We need to let countries prioritize. And we're actually facing the effects of that with this. So I always ask our partners, why do we need to do outreach clinics when we can just construct a facility, a health post that only needs $300,000? But we have got partners that go out year in, year out, doing outreach clinics, which are good to do. But the issue is like now the partners are out, we are at zero. So there is nothing that we have built that as a country now we need to move away, to move from there, to make progress from there. So that's another issue that has also affected us, that usually when you are a beggar, you take what you're given. When you're going at a table and you are the one begging, literally, you can't even negotiate. And that's one thing that I've also said when I have an opportunity to say, I think us from the developing world, it's high time that we need to up our game and take care of some of these small things. Your neighbor can come and support. It's good to have neighbors that can support you, but you don't need a neighbor that will come and even buy you tomatoes, vegetables. Maybe they can do something else, but for these small things, we need to do them on our own. I like what the Honorable Minister from South Africa said, that Global Fund is only procuring 10% of their ARVs, but back home it's over 90%. And I'm the one responsible for health financing. And when I look at what is happening now, it scares me. It really scares me. Over 1 million people are on ARVs, and all that is being financed by our partners. So we've been having discussions with our colleagues from the Ministry of Finance to say, I think some of these things we need to do them on our own. So we developed a health financing strategy. It will run up to 2030. Within there, the major base for the strategy is to make sure that we boost our domestic financing. So over that, we are talking to the private sector. We are establishing a health fund, but we are also saying healthcare in Malawi is for free for everyone. Yeah, so if you are pregnant, you find yourself in Malawi, you need a C-section, don't worry, we'll do it for free. But the question is, what is the cost? It's also choking us. So part of the solutions that we also want to implement so that we don't lose the gains that we have made on maternal health and adolescent health, we are trying to say what we can integrate. So integration now is a big agenda in Malawi. We have also told our partners that from now onwards, there are some of the things that you are financing. They're good to have, but they're not the necessities. Maybe we can take them away and focus on the priorities. Yeah. We are also happy to say that we've got our new partners that are coming in to support us, the Beginnings Fund. So some of the money that is coming in now, we want to make sure that we bring healthcare closer to the people. Where we need an outreach clinic, let's construct a minimum of a health post so that if anything happens, we can still continue with service delivery. Thank you.
Thank you so much. And I could hear the anguish in your voice on where do you procure all your ARVs from? Where do you get the funding? It's a tough one. Dr. Bashir, I know in Kenya has consistently invested in strengthening its primary healthcare and reproductive, maternal, newborn, child, and adolescent healthcare systems. However, with the development finance shifting and increasing pressure on domestic resources, like we hear from all our colleagues, how is Kenya rethinking its strategies to ensure sustainability and equity in family health services? And if there are any particular innovations you'd like to share with us.
Thank you very much. First of all, let me appreciate the extension of the invitation to Kenya on this platform. Of course, the impact is well known, that it was a bombshell we were not prepared for. But quickly we went onto our feet and retreated as a government, first of all, without our partners. Let me go back and say the progress we've done, especially in the space of HIV/AIDS. Our 95 is at 98, 98, 94. And the most affected program in this ODA cuts is the HIV program. As far as maternal health is concerned, the country already had some plans, long-term plans on UHC. So with this new government, which is now there 2.5 years, health is a major agenda, and UHC was a presidential call and agenda. So 2 years ago, we started our interventions on our PHC, starting from our community health workforce. We recruited about 108,000 community health workers. That is given stipend by the government of Kenya, both at the devolved level and at the national level. Trained, equipped, given gadgets, having their own, what you call, electronic community health information system. We're using them also to register for the social health insurance. And we also have started doing our, what do you call, the spoken hub for the PCN's primary healthcare networks. We have about 315 primary healthcare networks. Those are the sub-counties. Health being a devolved function for the last 13 years now, or 12 years, has become a blessing to us as a soft landing. And things are happening on the ground. We have increased our health workforce over the last 2.5 decades because of the devolution. When functions are devolved, the resources follow. At the national level, we were left with policy, technical support, assistance, and resource mobilization. So when this happened, we retreated, continuing with our programs on social health insurance. We had 4 legislations, all towards improving our health and for sustainability in the agenda of UHC. One was the UHC fund. Second was the primary healthcare fund. Third was the facility improvement fund. So what happens is that we had mandatory percentage of all employees giving their contributions to a mandatory health insurance. And the primary healthcare is being funded by the government directly. You walk into health facilities level 1, 2, 3, and the facility will be refunded, but you will not pay anything. So it's an exchequer contribution. The social health insurance fund is contributory, both unemployed or employed. And we believe this is our final vehicle to really sustainability. Integration of our silo programs into the social health program is something that we believe can help us. So after the retreat, we identified our critical health services that should not be disrupted. We identified out of the 41,000 health workers who were to be sent home from HIV space alone, not maternal health. We retained about 11,000, and it's the exchequer funding it. We called our parliament, we sat down with our donor and development partners. We gave them our blueprint on what you need to do. We are not out of the woods. At the same time, we're also struggling with the co-financing demands of Gavi and Global Fund and all others. We also plan to identify a PPP within our central banks and our commercial banks to come and give input into our logistic and commodity security for a time, soft loan, so that the facilities, as they recoup their costs from the social health insurance, every facility will be able to use the funds at facility level. It doesn't go to the central bank or the central devolved system. So all these are things that are likely to help us absorb the shock. But of course, the shock is big. Thank you.
Thank you so much. A good example of how countries are taking control of the financing and bringing in other partners, non-traditional ones. I've been remiss in welcoming Dr. Camille Shortar, the Director of Health Planning, Research and Statistics for the Federal Ministry of Health in Nigeria. Welcome. Let me turn to DG Usman Sis. We know that Senegal has shown regional leadership in health financing and multi-sectoral collaboration. In this rapidly evolving context of global health, where equity and rights are increasingly contested, how is Senegal leveraging political will and domestic innovation to safeguard and advance the rights and health of women, children, and adolescents? And could you share a few of your examples of policies or partnerships that are helping your government do so?
Merci pour la parole. Bonsoir à tout le monde. Je voudrais vous remercier d'avoir choisi le Sénégal pour participer à cette importante activité. Le Sénégal a réalisé des progrès significatifs dans la réduction de la mortalité maternelle et infantile entre 2017 et 2023. La mortalité maternelle passant de 236 à 153 pour 100 000 naissances vivantes. Et la mortalité infanto-juvénile est passée de 56 à 40 pour 1000 naissances vivantes. La mortalité néonatale a diminué de 28 à 23 pour 1000 naissances vivantes au cours de la même période. Des actes forts ont permis d'atteindre ces performances. Il s'agit entre autres d'une volonté politique forte au plus haut niveau par la souscription aux engagements internationaux liés au financement de la santé, un leadership fort marqué par la prise en compte de l'amélioration de la santé de la mère, de l'enfant dans les différents documents pour le développement socio-économique du Sénégal. Nous pouvons citer entre autres la stratégie nationale de développement issue de la vision du président avec le master plan et l'agenda de transformation systémique Sénégal Vision 2050. Mais également la lettre de politique sectorielle de développement qui est bien alignée avec la vision du président et qui prend en compte cette problématique de la santé de la mère et de l'enfant. Une augmentation constante du budget de la santé qui est passé de 216 milliards de francs CFA en 2021 pour arriver à 267 milliards en 2023. Le financement de la spécialisation des étudiants en médecine pour doter le pays en ressources humaines de qualité, qui est l'un des 3 piliers de l'offre de soins de qualité avec les médicaments, les infrastructures et les équipements. La promotion de l'assurance maladie, qui est un pilier important pour atteindre la couverture sanitaire universelle. La gratuité des soins de l'enfant de moins de 5 ans, mais aussi la gratuité des césariennes pour les femmes qui sont enceintes. La priorisation des interventions en santé de la reproduction maternelle, néonatale, infantile et de l'adolescent à travers un plan dit SRMENH. SRMENH qui veut dire santé de la reproduction, de la mère, du nouveau-né, de l'enfant, de l'adolescent et la nutrition. C'est ce qui a permis d'accroître les investissements, ce plan, durant les 5 dernières années, dans 6 régions du pays qui en comptent 14. où les indicateurs d'impact de la santé de la mère et de l'enfant étaient le plus bas possible ou notés. Le financement pour la construction des infrastructures sanitaires, où on peut citer les pôles mère-enfant, les blocs sous, qui veut dire soins obstétricaux d'urgence, ou blocs SONU, soins obstétricaux néonataux d'urgence. La mise en place des bourses de sécurité familiale et la carte d'égalité des chances, qui rentre en droite ligne avec l'axe 2 de l'agenda du pays, c'est-à-dire avoir le capital humain de qualité et l'équité sociale. La coordination nationale de la mise en œuvre des politiques de santé de la reproduction maternelle est assurée par une plateforme qui est multisectorielle, regroupant tous les secteurs ministériels ayant un impact direct ou indirect sur la santé de la mère et de l'enfant. Il s'agit des académiciens, des associations professionnelles, des organisations non gouvernementales, les partenaires techniques et financiers, les institutions parlementaires et les collectivités territoriales qui jouent un rôle important car dans notre constitution, la santé est garantie en parfaite symbiose entre l'État du Sénégal et les collectivités territoriales. Cette plateforme nationale déclinée au niveau des régions, mais également au niveau des départements, est constituée de comités techniques que sont le comité de la santé de la mère et du nouveau-né, le comité de la santé de l'enfant, le comité de la planification et le comité de la santé de l'adolescent. Pour la question de savoir quelques exemples, nous pouvons dire brièvement que le Sénégal s'est engagé depuis longtemps pour une efficience des dépenses liées à la santé. Cela s'est traduit par plusieurs réalisations, avec la mise en œuvre du financement basé sur les résultats, qu'on appelle gestion axée sur les résultats, la mise en œuvre du financement direct avec l'appui de nos partenaires techniques et financiers, le développement du partenariat public et privé, ce qui nous a permis la construction d'hôpitaux tels que l'hôpital de Touba, l'adhésion du Sénégal au fonds de contrepartie double, la mise en œuvre de la stratégie nationale du financement de la santé pour tendre vers la couverture sanitaire universelle, la signature d'une convention avec les associations des collectivités territoriales, mais également la mise en œuvre de la stratégie de la santé dans toutes les politiques pour assurer cette mission. On peut citer enfin la mise en place d'un delivery unit qui permettra un meilleur alignement des financements de la santé prenant en compte les priorités au niveau national. Je vous remercie.
Thank you, and thank you for outlining what is happening in Senegal. I think finally we move to Ethiopia. Honorable Gelgulu, who is a member of parliament and also involved with government, but really whenever we hear of Ethiopia, we think of the example that you've set of the huge number of community health workers and how they have the community health extension program, which has increased coverage of services for populations across the country. As a parliamentarian, what do you see the role that Parliament has played in supporting efforts to improve health outcomes? And in the current funding crisis, what more needs to be done? What other measures do they need to put in place when we're trying to safeguard the gains and also make more improvements? So maybe we hear from you.
Thank you very much for recognizing Ethiopia on the health extension work, community health works. Let me begin with commending the leadership of government of South Africa, His Excellency President Cyril Ramaphosa, for elevating this critical agenda to the global stage. Let me highlight to some of the national progress of the women's, children's, and adolescents of in Ethiopia. Ethiopia believed that firmly the health and well-being of women and children are not morally imperative, but also the foundation to our economy and also the social development. So over the past decade, as you may know, Ethiopia is prioritizing this maternal, neonatal, childhood, and adolescent services within its primarily healthcare strategy. So the maternal mortality is declining from 401 to 195 per 1,000 live births from 2005 to 2023. And similarly, under 5 mortality is dropped from 160 to 59 per 1,000 life mortality. So this data has been currently, we have been undergoing the demographic health survey. Probably this data may come up with updated one. So Ethiopia is investing because this has been come with some of the improvements that we've done on the community health work. Still, yet we have to recognize reaching every woman and children, especially to hard to reach, and some of the fragile setting that we have to address that. In the role of parliament, you know, in supporting health outcome is as a member of parliament, our role is initially in the current context of the constrained public funding, we are implementing some of the policy dialogue with Minister of Finance and also the microeconomic team as a country to increase the funding for the health and also what has been affected, like which areas affected, the maternal, the commodities, and so on. As I'm the one who's managing the national commodity, so we are really focusing on the dialogue and budget oversight because Ethiopia is a federal system, national and subnational support, and the parliament is oversighting on what gain in regard of this current constraint at the global shock, and also revitalizing our public health services, scaling of some of the comprehensive health posts that we have, and also the monitoring mechanism currently we are doing. So at the parliament side, we are really focusing on increasing the matching fund, especially focusing on the maternal and child health through the dialogue with the high-level budgetary of the government, which we call it parliament microeconomy. So one of the issues we focus in the improvement of supply chain. In supply chain, commodities affected. Initially, what we do is, before this constraint, the government is shifting, as you might be known, most of the digital systems in supply chain is more donor dependent in many African countries. So what we do is we took that digitalization to our own. So before this shock comes, we implement all our ERP system in our OS because of some of the funding. So nowadays, Ethiopia has its own digital systems on the premises. So if the shock, when that shocks happen, our commodity supply chain is not disrupted. So that might be the best experience that the country should take its own, the digital system, the supply chain system, which primarily affected. Once the product is affected, program is definitely affected. So in conclusion, as a parliamentarian, we as a leader, global advocate, we have to, deliver on the promise of equity and the resilience for every woman, child, and adolescents through strengthening, increasing the funding, in-country funding, matching, as well as including the private sector to have the funding up at the nation. Thank you very much, because he's showing me the minute.
To our final panelist, Dr. Shorter, with Nigeria's scale and diversity, advancing equitable access to healthcare for women, children, and adolescents it's a challenge, but also an opportunity. How is Nigeria leveraging data, planning, and partnerships to drive more effective investments and reach the underserved people? Any examples of scalable model that you might have, we'd be interested to hear of.
Thank you. And apologies for coming a bit late. I was in the other program in this same place, so I had to be called to come here. And apologies from my principal, Professor Mohamed Ali Pate, who will be coming during the week. For Nigeria, thank you for appreciating the diversity. A lot has happened in the recent past, and particularly under the current government. We are implementing the health sector renewal investment initiative using the sector-wide approach, in which we talk about the one plan, one budget, one report, one conversation, and one voice. What we've been able to do, we got all our partners to sign a compact with us. They identify with our priorities, and whatever they bring, we also bring something to the table. And then we spend effective and smart spend on those priorities. That is what has been happening in the last 2 years. And we have challenges of maternal mortality, infant under 5 mortality, which we are currently using data to address. Nigeria is a big country. We have 774 local governments. From the analysis we've done in the last 2-3 years, we came up with identified 172 local governments where most of the mortalities actually take place. So we design our approaches and interventions to go to these local governments and make sure that shortage of skilled attendants are addressed. Currently, we are on a drive to train and retrain 120,000 community health workers. So far, we've done 60,000. And let me at this point say that the current president we have in the country now has a dashboard in his office that is tracking the deliverable of every ministry and interventions real time. So there's no sloppy, there's no slowing down by anyone. Once you are given money, you must spend it effectively, you must be accountable, and you must show results. So what we are, in the spirit of swap, it has provided an opportunity for effective spend. Okay, and we have our challenges around routine immunization coverage also goes to this 172 local governments, and we involve the traditional community and religious leaders who are driving this. Nigeria recently introduced human papilloma virus vaccine, and we've been able to cover 12 million girls in less than 1 year. What did we do? The First Lady, wife of the President of the Federation, started the immunization campaign. And before you know it, every parent wanted the young girls to be vaccinated. So this is something we are doing. And we've also introduced the unlocking healthcare value chain. Now we're on a drive to produce most of our essential medicine in country. With the funding of USG, Nigeria quickly mobilized $200 million to pushing the effect of the ATMs, malaria medicine, tuberculosis, and for HIV, which these donor funds have largely supported in the past years. So we are rising up to the occasion, and we still want to work with all our partners, but at our own pace, defining our priorities. If you don't identify with our priorities, keep your money. That is what we have done now. Thank you very much.
Thank you. So you've been showing the donors the 1-minute card also, yes? But thank you so much to the panel for sharing their experiences. One thing is clear, it's about national ownership, where we have seen national ownership, where we see government taking steps to find financing modalities, forming partnerships, curating strategies to address increasing coverage even when the country faces conflict. And I think importantly, the localization has been coming through all our colleagues. When it comes to parliamentarians and others taking a leading role, it's important too that we've seen their involvement brings more focus and more national resources being allocated. At the end of the day, it's really looking at the health workers and the healthcare providers at the front line who will continue to deliver under difficult circumstances. But It's been wonderful to hear from all of you on how you're coping in these difficult times. Thank you very much.
We'll invite the second panel to come take the stage, please. No, you can sit wherever you'd like. No order. But no particular order. I'm going to stand because it'll be faster that way. So you take a seat. We have everyone. Pascal. Excellent. Well, thank you so much for our final panel of the evening. My name's Kathleen Sherwin. I'm the Chief Strategy Officer at Plan International, but more importantly, a very proud member of and board member of PMNCH. I'm probably also the newest board member, so Rajat has given me the toughest assignment in 25 minutes to deliver a number of key recommendations, and then there's a reception, so we're standing between a lot of that. So I know we have though many advocates on the panel, and so that's our job. We can deliver that. We heard in the first panel, and this was the task for the first panel, we heard from a number of governments, Sudan, Malawi, Kenya, Senegal, Ethiopia, and Nigeria, their key priorities. And so this second and final panel is to really deliver on a very tough homework assignment. What are the practical, pragmatic, cost-effective, and scalable solutions, recommendations, innovations, and practices? And so what we want to be able to do is keep in mind what are the recommendations that are available, that have impact, that can be scaled, and that are multi-sectoral. So we have an amazing panel of key partners and tough advocates. So just very quickly, I'll introduce them and then we'll jump right into the questions. We first have Saba Hussain, who's the Senior Director of Global Health Partnerships at Eli Lilly. She is leading 30/30 philanthropy portfolio, manages quite a few of the global health grants through the foundation, and has been with Eli since 1999. Wow, really amazing. A long time. We have my dear fellow PMNCH board member as well, Dr. Sanjana Bajwad, who is the Deputy Director of Program Advocacy and Communications at the Gates Foundation. Sanjana, in her role as leading policy and advocacies across family planning, MNCH, nutrition, primary health and systems, and of course is a medical doctor and public health practitioner, and again, one of the newest members of the PMNCH board. We have Usha Viswanathan, who is the Director of Programs at the Temasek Foundation. Much of her work is collaborating with governments and philanthropy, and really identifying maternal and child health needs across Asia and Singapore. Probably no introduction needed, Dr. Pascal Alate, who is the Director of SRHR at the WHO. Welcome, welcome. And we also have Bernard Ayite, a fellow influencer, the Senior Director of Policy and Advocacy at PATH. He's leading the design and implementation of key global health policy change and influencing strategies. So many, many advocates. So we're going to jump right into it. So I'm going to hold you at count 3 minutes each. That's why I'm standing the whole time, because I will run on stage. But really where we want to land is we want to walk away in 20 minutes with practical recommendations, practical solutions, practical innovations. So with that, I'm going to start with Saba. I'm going to come to you first, if that's okay. We heard in the first panel that we really needed to address inequalities and access. And keeping in mind how Rajat and Helen started today, we need to do better with less. So what opportunities do you think, Saba, exist for public-private collaborations, and ones that, again, prioritize access and equity? I'm sure the one might work.
Once
right?
something,
Okay, good.
something works,
Good.
right? So thank you very much, and thank you for having me on the panel. One thing I do want to say that throughout our history, Lilly has worked to address the most pressing health challenges facing humanity, including infections, diabetes, depression, cancer, and obesity. Our impact goes beyond the medicines that we discover. Our goal is to really address the complex health challenges around the world. And I think to your question, what you're asking is, how do we really close the gaps? What do we prioritize? We look to strengthen health systems to ensure sustainable and scalable interventions. We support community-led innovations that include people with lived experience. And I think there was a lot of conversation or dialogue around that, is really how do you strengthen health systems that are appropriate for the population or the country or the geography? And then how do you really tailor those evidence-based interventions that have proven to be effective, right? So I think that, again, then allows you to speak to both scale and sustainability. And I think another thing that was spoken about was how do you bring interventions closer to the community? And that's where we focus. We focus on primary healthcare, community-led interventions, the voice of the community, and as well as digital solutions, realizing where we are currently in looking for digital and AI solutions. And some of the key examples, and before my minute comes up, some of the key examples that really speak to these interventions or this sort of theory of change that, or the journey that we're on, is our engagement with UNICEF, USA since 2022. We have worked through their efforts to improve NCD care for millions of children and adolescents. And the key driver of this progress has been strong community engagement, especially trusted community health workers that build both trust and accessibility, and helping identify NCDs early, right? So that is the key. And then really linking families to care and building vital connections between community and the health system. And I think this education, awareness, working with community leaders, working with community health workers, more training of community health workers are really the interventions that we support. And we come in and we've seen the evidence of that change. Another one around technology that I just want to make sure, because there is so much around discovery, innovation, is really bringing the right tools within community to the lowest levels of care with the goal to improve longitudinal health outcomes. So one key example that I did want to share is our support of work through Panorama Global to Moi University and AMPATH Kenya to really enhance AMPATH's patient-centered primary care with the goal of introducing point-of-care ultrasound. And that cannot be introduced without the device, without the training, without really, and what does this do for a population or a population health if you think about it? It really changes the trajectory of health, right? It basically provides an opportunity of early diagnosis for improvement, if you think about it in the case of pregnancy, heart failure, breast cancer. And this has an impact on maternal, newborn, child, and adolescent health. So you have to take those measures to really shift to a paradigm of early diagnosis, of prevention, and working within communities.
Excellent. Thank you, Saba. So thank you. And two great examples, a partnership with Eli Lilly, one with UNICEF on NCD care, and thank you for the second on the Panorama Global with point of care access for ultrasound. So thank you for those two examples. Sanjan, I'm coming to you. Hello, fellow board member. How are you? We've heard today, or we'll hear all week, we're in difficult, challenging times. The global health architecture is changing, the development models, refreshing, changing, building back, building better. There's lots of ways you can talk about it. And as we rebuild, and we have to do better, I know the Gates Foundation has made a number of significant announcements around this theme. So curious, just how can philanthropy support country-led solutions without creating parallel systems and systems of duplication? And what measures perhaps is the foundation specifically considering and encouraging its peers to adopt? So back to some solutions.
Thanks, Kathleen, and hello to everyone. I think there's one thing that we all share in common right now, right here in this room, is optimism, right? And at Gates Foundation, we do believe we are eternal optimists, and there's reason to be optimistic about the future. We've seen the data. I know Julia presented some of it. There is much to be celebrated in terms of the progress made. We've heard from the leaders in the previous panel, our government leadership, the minister, Honorable Minister, South Africa. There's a lot of energy from country leadership that is really driving the change that we all want to see. And I think from our perspective, we've always been guided by country priorities, country needs, and how the country wants to define the agenda, set the agenda, and really calls for what solutions are needed at the country level to meet the unique needs. And I think that's where some of the optimism comes from, because I think today we have the data that we never had before. We not only have the data to understand where the problem is, what the problem is, why are children dying, why are mothers dying, but more importantly, we also have the data on the solution side. We know what works. I mean, there's the science to prove it. We know exactly what are the low-cost solutions here. The foundation has done a lot of work, but we couldn't have done this without, I think, almost everyone sitting in this room. I think that, again, gives us call for optimism. The ingenuity and the energy and the fantastic partnerships that we have with everyone. I think there's a lot of sort of drive to see and transform the world in the next 20 years and make sure that no mother, no child, no one dies of a preventable cause. So I think that's very powerful in terms of what we believe in and want to work with. Some tangible sort of, just hearing from the previous panels. And also, I think what the Honorable Minister in South Africa, Minister Motsoaledi, you mentioned, the argument one makes on the HPV vaccine, for instance, on how we can make a strong economic argument for the work we're doing becomes very critical in today's time. We know that every $1 that you invest on maternal health, for instance, saves $3 in saving their healthcare costs that can happen because of complications and other things. So I think those are the kind of critical arguments that we need to make to support ministers of health, ministers of finance, for heads of state and others to make the argument. Just a couple to end with a couple of examples. I think we're very energized and sort of inspired by the partnership that is, of course, hosting us today, but also the Global Leaders Network, where you see the leaders coming forward, the heads of state, to really make the case for women, children, and adolescents and to focus on health and nutrition. That's a very powerful message that we're sending out. There was a lot of mention of supply chains and commodities, and I want to lay some attention on that. I know we work very closely with the UNFPA Supplies Partnership, and that really banks on country leadership and countries defining their commodity needs, but more importantly, for collaborative philanthropy to come together and really make sure that you have pooled financing available, that countries are able to strengthen their supply chain systems, which become absolutely critical to make sure the woman at the last mile has the commodity needs that she needs. I want to end by just also acknowledging, what Minister, I think the colleague from Malawi mentioned, the Beginnings Fund. And many of us in the audience have heard about the recent announcement of the Beginnings Fund, which was such a unique philanthropic initiative. I personally was involved with that entire process for the last couple of years. And I have to say, it's been one of the most inspiring things for me in my career to see how the different sort of, partners can come together, but very focused. It is targeted investments. It's country-led. You heard the Malawi colleagues say that. And it rests on country investment plans that countries decide what needs to be done, where it needs to be done, that has the biggest impact on reducing maternal newborn. So I think the importance is country leadership. The importance is the context for the challenge and the catalytic solution that philanthropy could bring to the table. And it really rests on that collaboration with partners, stakeholders, researchers, academics, and most importantly, the women and children on the ground, the civil society networks, and others.
Thank you so much, Sanjana. And some great examples. Sanjana shared the Global Leaders Network, the UNFPA Supply Partnership, and the Beginnings Fund. And I just love also what you said. I know you said this at the board meeting. We know what works. Country knows what works, and now we have to bring it to scale. And that's an excellent reminder. Usha, I'm going to come over to you. So we're going to skip around a little bit. Usha, the Temasek Foundation has been obviously at the forefront of fostering cross-sector innovation and regional cooperation. I'm so curious, just in a funding environment, obviously that's scarce and tough, how can philanthropy and public health sectors align better to drive innovation for women and child and adolescent health? And what kind of partnerships have you found work best in achieving this impact, particularly in low and middle income settings? Usha?
Thank you. Can you hear me? Thank you for inviting me for this very important discussion. And I think what needs to be said, and we've been hearing it this evening, is acknowledging the tremendous amount of work that has actually been done in addressing women and child health over the past years and continues to be done today. I think, when you look at Asia, we have seen increase in the we are seeing that there has been a lot of improvement in healthcare systems as well. But the truth and the reality is there's still a long way to go. We are not there yet. We can't take the foot off the pedal. And Asia has one of the highest burdens of maternal and child health mortality today. And this is something I think the governments recognize. And, as a philanthropic organizations, this is what we would like to collaborate with the governments, with the private sector, to see how we can actually and Singapore doesn't come as top of mind when you think of maternal and child mortality. But what Singapore does is it provides a sandbox to actually pilot solutions that to see how we can then scale and sustain it, not only in the country, but also in countries in the region. So I would like to actually say from a philanthropic organization point of view, there are two principles that I would like to actually, for you to take away. The first one is leverage philanthropic capital to actually pilot, solutions which could be innovative, which are bold, because these are solutions that the governments or the public health sectors typically will not fund. But what we can do is actually pilot them to show proof of concept, to show proof of value. And once we can actually show that, then we have the public sector, we have the governments coming in to then take it and scale it. And this is the most important principle. The second is always to engage and to partner with the local governments, because it's very important that the governments are involved so that, once you have finished a pilot, they can then be sustained and scaled in the long term. So this is something that, I would like to leave with everybody, because we heard from the previous panel, it's all about PPP. So yes, we have philanthropy, public as well as private, but how can we actually come together? And the last example I would like to leave is it's an example from Singapore, which has now come to the Southeast Asian region. We all know that maternal and child mortality does not exist in isolation, because it is a 360. There is health, but there's also social challenges, there are educational challenges. So we piloted a program where we actually enrolled the mother right from her pregnancy. And we did a kind of primary healthcare worker who followed the mother till the child was 3 years of age. For the entire period, the family, including the mother and child, was followed by a single primary healthcare worker. And it was not just health. It was also social determinants, also on education. And at the end of the pilot period, we could clearly show that there was health outcomes, but also there was an improvement in the social and economic standing of the family. And I'm happy to say that this program is now going across to other countries like Indonesia as well. So this is something that I would like to share.
Great. Thank you, Usha. And I love the two principles: leverage philanthropic capital for pilots, building your proof of concept, and of course, obviously key is working very, very closely with the local government. So thank you for those two principles. I think we're going to go over to Bernard now. Hello.
Hello.
So I have a tough question, I think, for you. I think everyone here in this room agrees, and I hope most around the world, that no woman or child should die during pregnancy or childbirth. So the question is, where is our advocacy failing? Whether, we see investment lagging and we see progress slowing. So what are we doing wrong? how do you see looking at effective advocacy to ensure that the agenda that we've heard today from governments stays on the agenda as we go forward, even though civil society may see shrinking resources and budgets, but how do we go forward and still build a successful advocacy agenda? 3 minutes, very easy question.
Thank you. I was just thinking, actually, just as you asked that question, if the woman that I live with and the 2 adolescent girls I live with were asked that question, what is he? I mean, I think, seeing all the advocates in this room and beyond, it's clear that we're all in agreement that, no woman or child should die prematurely or from preventable causes. And yet, despite that agreement, there is this wide chasm between the rhetoric and the reality. And so it's really clear that on top of the fact that we have this agreement, we have a lack of progress and an investment that is lagging behind. And it often seems to me that one of the things that we get wrong is that we are, broadly speaking, often talking within an echo chamber. Within this week, we all convene at WHA and we're speaking to a lot of people who agree, and we present the compelling data and the evidence, and we make really clear ask about the need. And yet that's not always cutting through. We've got progress, and Julia set that out really clearly, and that's due to a lot of the work that's been done by people in this room. And at the same time, we also know that it's very difficult to break through with decision makers in this moment where there are so many priorities to be thinking about. And it's clear that we're going to have to be much better at telling those stories, those human-centered stories that hide behind the statistics, but also finding ways to apply the behavior insights that we often apply when we're thinking about how to keep communities on their drug regimens and thinking about the social behavior change that is required. We also need that for decision makers, decision makers who have a lot of things coming at them and trying to work out, well, I've got this data, but there are lots of reasons and lots of inertia for not taking this course of action that I know that is right. And so that's one of the reasons that PATH is doubling down on our approach to supporting decision makers to really apply that data.
Great.
Is that my cue to shut up now?
Well, you have a very good one. So I think a round of applause to that. I mean, I think, again, what you've said is better human-centered storytelling and applying that social behavioral change. And I just love what you said is supporting decision makers, using our advocacy to do that. So thank you for that. We have one more speaker. We're still going. Okay. Am I passing? Okay. Just making sure. Whew. So Pascal, last over to you. We heard from the previous panel quite a bit of support, of course, for strengthening and protecting the SRHR agenda. And so curious, how do we gonna get organized and be able to provide this support in a very complex environment that we're navigating over the next year? How do we make a tangible difference? And maybe to be super concrete, can you give us 2 or 3 things that we should be doing now this year to be able to advance that agenda?
Okay, I stand between you and food. Okay, so colleagues, the promise of the SDGs and the global strategy for women's, children's, and adolescents' health, which we're discussing now, in fact, any strategy that acknowledges equity, diversity, vulnerability is at risk. Inequalities and inequities are widening, rights are being rolled back, and too often our partnerships are being shaped not by need or equity, but by competition. Competition for attention, for resources, and for influence. And we must do better, and we must do better together. I want to offer a practical example of what this looks like in action. The UNDP, UNFPA, UNICEF, WHO, World Bank, GFF Special Program of Research Development and Research Training, HRP, which I have the privilege of directing, is a unique co-sponsored program which over the last 50 years has delivered cutting-edge evidence, advanced norms, has advanced norms, global norms and standards, and supported countries to implement life-saving solutions, especially in the most neglected areas of sexual and reproductive health and rights. So if you know about emergency contraception, you know about HRP. If you know about mother-to-child transmission of HIV, the use of zidovudine and single-dose nevirapine to prevent vertical transmission, you know about HRP. If you've drawn on the guidelines for digital health interventions or self-care interventions, you know about HRP. If you've used estimates of the maternal mortality, global estimates on gender-based violence or postpartum hemorrhage bundles, or the comprehensive abortion care guidelines or management of post-rape care, including in humanitarian settings, you know about HRP. This is a partnership or co-sponsorship that was set up specifically to continue to generate and drive the evidence to support and inform implementing partners across the multilateral system within member states and with civil society to address the underlying persistent injustices that are critical to women and to gender equality. But the true strength of HRP lies not only in what it produces, but in how it works. And this is really important in thinking about partnerships. We have to align. It brings together agencies with different mandates, technical expertise, and constituencies around the single agenda of sexual and reproductive health and rights across the life course, contributing to work plan, budget, and accountability. And it leverages comparative advantages of each partner to try and avoid duplication, inefficiency, and fragmentation. The critical thing here being we have to be intentional. We actually have to work at being good partners. This is precisely the sort of partnership we need for this particular space. And the one pivot that I do want to mention before I hand over and let you go and eat, is to recommend, in terms of the space that we're in, a complementary narrative that keeps SRMNCAH as a niche area, and that tends to focus solely on cuteness of babies and the role of motherhood as the primary way of defining womanhood, to one that recognizes that to thrive, that which makes us women is also what makes us productive, not just reproductive. There are therefore opportunities to be smarter with less as we look at integrating these issues within other priorities within global health. There is no reason we should be talking about NCDs without talking about women. There's no reason we should be talking about infectious diseases without talking about women, and we need the evidence to be able to do that and do it.
Great. Thank you, Pascal. And we'll leave it with that as our last good example of partnership. And thank you again for your leadership on the special program of HRP. So with that, Rajat, I hope we did our homework. We've heard a number of core recommendations and solutions, all again in terms of joining forces together. And I think these are examples that we have done more with less. So thank you all to our panelists, and we'll turn it over to Rajat to close the evening. Thank you.
Thank you. Thank you so much for that, Kathleen. Trust me, colleagues, I'm not going to drag this along. This has been a long evening already, but a few quick wrapping up remarks from me before we close. The first is a big thank you to all the speakers, moderators, to all of you for staying through the evening, for coming and for engaging in the discussion. The second thing I want to say is something slightly more basic. There is some cards with QR code at the back. This is the recent data that has been compiled as part of the global strategy update. Please do have a look at that. A lot of what you've been hearing is available through that brochure that is available at the back. Colleagues, two final things before I let you go and enjoy the reception. The first is, as I started by saying, status quo is certainly not an option. We will and we must not accept the present as a given. As multiple speakers, one after the other, narrated, partnerships lie at the core of us delivering in these challenging times. So let's work together. Let's stand together. And most importantly, take care of yourself. This requires the best of all of us. Thank you.